Thank you, Northeast Cardiology Update, for giving me an opportunity to present my case today. I am Dr. Dipankar Das. I'm a consultant cardiologist at Narayana Super Speciality Hospital, Guwahati. My case is not that hi-fi case type, but it is just a feel-good factor for me. So I'm going to present my case. So my case is a 49-year-old male patient who is a smoker and hypertensive, but he is non-diabetic. He presented to us in the emergency with one-day history of retrosternal chest pain associated with excessive diaphoresis. In the last 1 day, he was having intermittent chest pain. So there was no history of any breathing difficulty or palpitation. So on clinical examination, he had a pulse rate of 98 per minute regular. BP was around 158/92. His chest and CVS examinations were within normal limit. The respiratory rate was around 20 per minute. So ECG was done in the emergency, which revealed significant ST depression from lead V3 to V6, 1 and AVL. And then TROPI was done in the emergency, which was high. And NT-proBNP was although in the normal limit. So echo was then done, which revealed no RWMA, and the ejection fraction was near normal. So a case of CAD, acute coronary syndrome diagnosis of NSTEMI was then made. The patient was then loaded with ticagrelol, ecosprin, and rosuvastatin at requisite doses. Because of ongoing angina intermittently, he was shifted to the cath lab for coronary angiography. So coronary angiography revealed this we used a 5 French radial sheath, and 5 French Tiger catheter was then used to hook the coronaries. In the RO caudal view, we can see that the distal left vein is significantly stenosed. It is around 90% stenosis. There is slight calcium present at the distal left vein. Also a large OM can be seen as having a slow flow, most probably with thrombus. This is the LAO caudal view, which revealed significant right distal left main stenosis with involvement of ostial LAD being around 90% stenosis, and also involvement of around 60-70% stenosis of the ostial LCX. So this is a left main bifurcation disease with involvement of both the ostial LAD and the LCX. This is the PA cranial view. This is the RO cranial view. The RO cranial view is showing that the left mid LAD is also significantly diseased, around 90% stenosis with involvement of a diagonal. The RCA, however, was normal and dominant. So a diagnosis of NSTEMI with double vessel disease and critical left main bifurcation disease was made. Now, the question was how to treat this patient. So for this type of disease, we have two options: either go for bypass surgery or go for multivessel PCI. Because of ongoing acute coronary syndrome and angina on and off, PCI was favored. Now, again, LMCA bifurcation stenting can be done by mini crush technique or decay crush technique. But because of intermittent chest pain, the patient was in agony, so a choice of mini crush was then made. So immediately femoral access was gained and a 7 French sheath was inserted. JL 7 French 3.5 was then taken to hook the left coronary, and mini crush technique was then decided to do the PCI. 7,000 international unit of heparin as per the weight of the patient was given intravenously. So after hooking with JL, 2 run-through hypercoat wires were then used to wire both the LAD and the LCX. Pre-dilatation of LAD to LMCA to LAD was then done with 2.5 NC balloon, 2.512. And also the mid LAD was then dilated with 2.512 balloon. So post ballooning, we can see that the lesion has opened a bit in the mid LAD. Then even the ostial LCX was, LMCA to ostial LCX was then inflated with an NC balloon. Thereafter, 2 stents were taken. Into the ostial LCX was placed 3 into 20 Promas element stent. And into the LMCA to LAD was taken 3.5 into 20. In the mini crash technique, we take both the stents together, and hence the need for 7 French guiding catheter. So after placing the LCX stent in the ostial LCX with slight protrusion into the LMCA, the LCX stent was then deployed at 14 atmospheric pressure. Post deployment of the ostial LCX stent, the wire and the balloon were then taken out, and LMCA to LAD stent was then inflated again at 14 atmospheric stent. We can see that the LCX stent got crushed. This is the shot after the stenting. Then we did we recrossed the LCX stent and then inflated with three balloon, and then by this one, and then kissing balloon was then done with 3.5 balloon in the LMCA to LAD and 3 balloon in the ostial LCX. This is the kissing balloon, and then POTS was done with a 4 into 8 balloon. Then after that, I did the mid LAD lesion also with 2.75 into 38 balloon, and then inflated and then post dilated it. This is my final angiographic shot. We can see that there is well expanded stent in both the LMC, LAD and the LCX with a neocarina. This is the RA caudal view. We can see that the flow is TME3 in all the vessels. And this is the post-op ECG. The ST elevation, ST depression has significantly reduced. So post-procedural period was uneventful. The patient was discharged on day 2. He still follows up in OPD and is hale and hearty and stable. Thank you.